and take it away, Dr. Harigopal.
Okay, thank you, Dr. Heswell. So this is a topic of interest for, I'm sure, a lot of residents and those who want to be in pathology. So one of my motivations to do cytopathology in the United States is because they never offered us cytology as a subspecialty in India in 1994. Things have changed now, but I feel like, that was one of the early reasons why I came to the United States. And from then I did a fellowship in cytopathology at Cornell, and then I went on to do a breast fellowship. So these are the two areas that really excited me. So let me share some of the specimen types that we get in breast cytology. So here's what we get. Normally, we would see a little bit of nipple fluid cytology. This is not a very popular specimen. You might get maybe 3 or 4 in a month. And defined needle aspiration biopsy, which used to be the method before the core biopsy actually took over. And there are other cytology specimens that you would encounter, like the touch prep cytology, and I find that useful. When you have a core biopsy, you can at the same time touch the specimen, the core, and you can get an immediate interpretation within like 10 minutes. So it just helps you with the adequacy of the specimen. So that's the benefit. And ductal lavage, I think it is not as popular at one time. It was getting popular for, especially through the nipple, getting specimen and aspirating it, but truly it has not taken off. So it's a very tedious process. So let's talk a little bit about the normal breast. The normal breast has like 15 to 25, contains 15 to 25 lactiferous ducts. They originate here in the nipple, and then they branch as they go down into the breast parenchyma and into small ducts and ductules, and finally end in the terminal duct lobular unit. And those are the acini. So you have an inner layer of cuboidal cells. So this is just a schematic representation, but you would have to look at the real specimen to know what I'm talking about. You have an inner layer of cuboidal or columnar epithelial cells and an outer layer of myoepithelial cells. It's really important to understand in breast pathology the 2 cell layers, because the 2 cell layer having the myoepithelial cells is really a sign that this is a benign process. And it can be lost in invasive cancers, but it's still retained in the in situ carcinomas. So let's keep going. I have a lot of slides. So
excuse me, Malini, could you switch to presentation mode so we get the full
view? Yes, definitely. Where is the presentation?
From current slide?
From beginning, okay. Oh, that sounds better.
From current slide, the next one over.
Oh, yeah, I'll move forward, yeah. So the nipple discharge cytology, this is, if it is
it didn't switch yet. It didn't switch yet.
Oh, okay, what happened now?
Maybe just that little presentation button at the bottom right. Just before the bar. Oh, and now switch screens, because we're seeing the presentation page.
Okay, I think one moment. Yeah, so let's go back.
The display settings, switch screens.
Let's see.
Up at the top, it says
display settings. Screen display settings, yeah.
Yeah.
Swap, present.
Swap, yeah, swap will do it.
Okay, sounds good. Is that better?
Yes.
Okay, sounds good. Okay, so let me go back to that first slide. So in the nipple discharge specimen, when it is spontaneous, that is not related to pregnancy or lactation, then it is something abnormal. So normally you should not have discharge from the nipple. And when you start seeing nipple discharge, it is probably related to either papilloma or fibrocystic changes or malignancy. And the characteristics of the specimen would be very few, it will be usually hypocellular. There will be foamy histiocytes and apocrine type metaplastic cells. So we found that the nipple discharge specimen is really not a very useful screening test, because 7 to 14% of patients are usually asymptomatic. And most of these nipple discharge specimens are not malignant, but sometimes when 2% only of breast cancers can be detected by this method, interestingly. So here is a sample of a benign nipple discharge on your left, and you see how hypocellular it is. You see a few ductal cells. You see a lot of foamy histiocytes, and the ductal cell quality is also important to observe. It's very cohesive. And as these specimen gets a little bit more three-dimensional, when it gets hypercellular, then you have to worry that this is going to be like an intraductal papilloma and probably needs to be excised. So let's talk about some of the utility of high needle aspiration, which is a more popular method for getting breast aspirates. It's usually used to evaluate cystic lesions, and it can be curative because if you aspirate the cyst and you get just watery fluid, it's probably going to not be, the cyst will vanish. It's mostly a benign diagnosis in case of a patient is presenting with a lactating adenoma in a pregnant or lactating woman. If you see a mass and you have a fine needle aspiration of it, and it supports a diagnosis of lactating adenoma, then the patient really does not need to have a surgical excision or even a core biopsy for that matter. And if you have a malignant diagnosis, then you have several discussion points to have with the patient about the options that are available, whether it's going to be a lumpectomy versus a mastectomy, and those are the things that you would discuss. Also, another way of diagnosing a recurrent or metastatic breast cancer, this is a very useful modality, and confirming a locally advanced cancer. And in terms of patients having a lymph node, the axillary staging would be very important if the lymph node is positive. So the technique of fine needle aspiration itself is, it is a technique that can be learned, but it needs a lot of practice. So this is a diagnostic technique that helps get cells out of the tumor, and using a very thin needle. This technique was popularized initially in Europe in the 1950s, but then it was Martin and Ellis who brought this, who actually used this technique. They were actually technologists at MSKCC, I heard, and in the 1960s, and they introduced this method, but it didn't get very popular until up to 1995 or close to 2000. That's when people started using FNA more frequently in the US. And where can this be performed? It can be performed as an outpatient setting. It can be done in the office, clinic, or even in the bedside. It's a very simple technique. And it helps you evaluate superficial breast masses and also certain non-palpable lesions, which needs, of course, ultrasound guidance. And deep-seated lesions would also need image guidance. So according to DeMay, he had this acronym where he said it was SAFE. So simple, accurate, fast, and economic. It also gives you a very rapid diagnosis. And the beauty of this method is the cells are very viable, so it's very unaltered. And there's no scar from any surgical. This is not a major procedure, so there's really no scarring. And if you have enough material, you can also do biomarker studies. And the more important in today's world is doing evaluating response to neoadjuvant treatment. So I think you understand what neoadjuvant is. When you have a patient who's diagnosed with breast cancer and they treat before the surgical excision and there's response or not, you want to evaluate, and you can use the lymph node to assess whether there was response. And this is actually, they leave a clip node in the lymph node, so you can it's important to find that clip node. And so the FNA is one way of evaluating the lymph node stage, and following this, you will be able to assess for that clip node later when you get the excision. It's also very inexpensive compared to open surgical biopsy. Of course, the disadvantage of this is you have to have availability of skilled aspirators and cytologists, and they should be familiar with, because those most surgical pathologists are very familiar with architecture, but not so much with the cells, themselves. And of course, there's very limited sample size. And then one more important difference between a surgical biopsy and a cytology specimen is you cannot tell the difference between an in situ versus an invasive carcinoma in a cytology sample. Whereas in a surgical biopsy, you will be able to tell this because you have the context of architecture, you have stroma, and you have cells infiltrating stroma, but you don't have that advantage with cytology specimen. And of course, LVI cannot be assessed on a cytology specimen. So complications are very rare. You can have bleeding and occasionally an infarction of a fibroadenoma or a papilloma. And the needle stick injury, I mean, if you follow safety procedures, this should not be an issue. So what is the diagnostic accuracy? Usually it depends on the operator completely. It's the skill of the operator that will determine the type of the specimen you obtain. Sensitivity is very high, 65 to 98% for the malignancy. Specificity is 34 to 100%, not bad. Positive predictive value is almost 100%. Negative predictive values. So when you say something is negative, how certain are you it is negative? So that is also pretty high. So the false positive rates is mostly very low, and they tend to be due to an interpretation error more often. And false suspicious rate can be high because, again, depends on the interpretation of the specimen and the type of specimen and the type of malignancy. False negatives tend to be around 3 to 20%. Again, depends on both the sampling and interpretation. So the accuracy, of course, would be limited based on the size of the tumor. So a lot has to go into the obtaining, doing a breast FNA. You have to have sufficient training and planning. It has to happen much in advance. And basically, you should be able to have a very multidisciplinary setting with good imaging information and with a radiologist. And where can this be performed? It's a very simple process. So you could do it either at the breast center or a dedicated FNA or on the bedside, depending on what type of institution you are working at. But more importantly, before you do an FNA, it is you have to obtain the history, review the history thoroughly, and check if this FNA is really justified or not. And the lesion has to be palpable. There is no point in going after a lesion if the clinician says he found a palpable lesion, and when you are feeling it, you are not able to find that lesion. It is not possible to do the FNA unless you can have somebody localize it for you and call the clinician to see if you can palpate that particular lesion. So the only complications I think that is more serious would be the pneumothorax if you're close, especially when you're going into breast specimen and if you're close to the chest wall, the patient is thin-built. If you puncture the pleura, you may end up with a pneumothorax. The needle tracts, the seeding of malignant cells into the needle tract itself is extremely rare. And there's no real contraindications except maybe some believe the patient has a bleeding disorder. So this forms a triple test, which cytology is one arm of the triple test. So it's a diagnostic triad consisting of a combination of both the clinical exam, the radiological findings, and the cytology findings. So when all of them are concordant, that is, the imaging is benign, and the clinical exam is suspicious for maybe a fibroadenoma, it's mobile in the breast, and the cytology yields a fibroadenoma, then it's concordant, and the negative predictive value becomes 100%. If all three are malignant, there's a very little chance of an error. So let's go over some basic equipment that is required for fine needle aspiration. And so the material that you would need is a chemical syringe pistol. This pistol is used to stabilize the syringe and needle. In many centers, I have noticed that a lot of people are just comfortable just using the syringe and needle without the pistol. And that works for certain types of specimens. For example, like if you are going into a thyroid, but in some very fibrous tissue, it's probably better to use a pistol because this will help you get more material, and because of the stability of the pistol affords you. You need a 10 ml disposable sterile syringe. Usually we use a very fine needle, like a 23 to 25 gauge needle, which is 1 to 1.5 inches. You need alcohol swabs, gauze pads, and glass slides, which are frosted in the end because you need to write the patient identity. You need to have the name or the medical record number on that, and you have to have gloves and a slide holder to keep the slides on it. So, and don't forget, you need transport medium, which is either saline or if you're suspecting a lymphoma, after your preliminary examination, you want to make sure that you put some of the material in the RPMI solution. And of course, the cytolite or the cyto-rich red fluid, which helps you to obtain material for cell block or thin prep. And then you need alcohol spray fixative, which can be directly done as on a wet slide, or you also could use a Copland jar filled with 95% alcohol. And local anesthetic is really not required unless the patient is nervous, and you might have to try to dissuade them from using a local anesthetic, because the prick from the local anesthetic is another process. So you could probably avoid it. So all of this material can be assembled in a basket, and it occupies very little counter space. So this is actually the procedure itself. Here you see the needle. It is right in the center of the mass, and you would withdraw the syringe so that it creates a vacuum here, and you go with very brisk motion in several directions, like you can describe a cone in it. So you could go multiple times, so suggest like 10 to 15 excursions into the lesion itself, so that you cover a large part of the lesion. And then when you start to see material appearing in the hub of so you go back and forth, and then if you see material appearing in the hub of the needle, you release the syringe so that the plunger, and so you reduce the vacuum or make sure the vacuum is equalized so that you don't have material coming into this. Is a very critical step, because if you continue to keep the plunger up and you pull the material out, then all the material that's inside the hub is going to splatter into this syringe, and you will not be able to retrieve that material. So this step has to be keenly watched. And then once you release the vacuum, pull it out the needle, and then detach the needle from the syringe, fill air into the syringe, and now again reattach the needle, and now you can put the material on the slide. So this is very important to get good quality smears. So the smear preparation, this is a skill in itself, and this is where you can get very good material, but if you do not follow the proper methodology, you can end up with very bad slides, which is not interpretable. So there's one smear method where you just express the material on the slide, and you have a spreader slide that you just pull the slides apart. And there's another method which is called the two smear method, where you do horizontally, and there are videos to explain how this is done. And then you can use one for air drying, which takes up to 15 seconds. The staining is very simple. There are only 3 steps involved, and the total time is probably 15 seconds for the staining. And you can interpret within 5 to 10 minutes. And then the rest of the smear, you would put it in alcohol. In addition to that, do not discard the needle. After you've expressed it on the slide, you have some material in the needle, and it might still be in the hub. So you want to extract as much material as possible. So you can rinse the needle into saline or any of the cyto-rich red fluid, and you can salvage this material for thin prep. And also, if you have a dedicated pass, you can even do a cell block, because cell block is going to be giving you a lot of information for ancillary studies. If there's a lot of blood, I would suggest you put it all in the cell block, in the cyto-rich, and create a cell block, and you can retrieve a lot of cellular material. So the 2 types of stains that are commonly used are the air-dried or the Diff-Quick, that we call as a Romanowsky type stain. And the reason why we use this for immediate interpretation is it exaggerates the differences between the nucleus and the cytoplasm. And although you do not get very good nuclear details, you can see the stromal component very well. So for example, if you have mucin and colloid and basement membrane material, these will be picked up nicely. In the pap stain slide, it'll take 24 hours because this goes into the lab and has to have a long process for staining. But you will see within 24 hours, the slide material is more excellent because it has nuclear membrane details. But for your immediate interpretation, a diff quick is good for assessing adequacy as well as maybe give a preliminary interpretation. So how do we report breast FNA? And just like in any other organ system, how we call for cytology, we call it either negative for malignant cells, atypical when the probability of malignancy is low, suspicious when the probability of malignancy is high, but then the cells are very limited. They are highly atypical, but you cannot call it positive outright because there are fewer cells or there's preservation artifact. So there are multiple reasons why you would call it suspicious. And for example, invasive lobular, well-differentiated ductal cancers, it's not very ugly for you to actually give that interpretation as positive. So limitations are there. And for positive, of course, you should be very, very certain something on cytology is positive to call it positive. And of course, there are specimens that you can go outright and call it positive. Non-diagnostic is an entity which, is characterizing something that is, you don't have enough material. So what is the adequacy criteria in breast? Just like in other organ systems like the thyroid, you have some adequacy that will help you determine whether you're actually having enough cells to assess to give a non-diagnosis. For example, if you have less than 6 groups of epithelial cells with less than 5 to 10 cells, then it is inadequate. So do not reassure if you don't have enough epithelial cells, do not club it and put it in the category of negative because that gives a wrong diagnosis. You have to be very certain that you have enough material to call something negative, or otherwise you are not going to be doing justice to the patient. So the other things that you want to visualize in a cytology specimen is, of course, you have to have a low power and a high power examination. And the low power gives you a lot of information about the cellularity. Is it hypo or hypercellular? What is the cell arrangement? Is it forming 3-dimensional clusters? Is it cohesive, discohesive? Is it single cell pattern? And also the background. You get a lot of information from the background because is there necrotic material in the background? Is it inflammatory type of infiltrate, or is it just a lot of myoepithelial cells, which they call as the naked bipolar cells? In any textbook, you will hear those cells in cytology. And under high power, you would want to examine the type of cells that you see. Is it epithelial cells, or is it mesenchymal type of cells? You can examine the nuclear details more carefully in terms of the nuclear membrane irregularities. Is there pleomorphism, chromatin pattern, and so on and so forth. And also, of course, you want to examine the cytoplasm and see if there's vacuoles like clear cell change, apocrine change. These are all things that you would put them together. Your low power and high power examination is going to help you understand what is going to be your final. So cytology is like a puzzle. You will have to put all of the pieces together to come to a final interpretation. So this is much of the same thing. So for a benign aspirate, of course, the cellularity is low, they say, but if it's a fibroadenoma, you can have a high cellularity. So I think you cannot go by these guidelines. There are exceptions to the rule, but generally low cellularity predicts that it could be benign. And cohesive groups are usually considered benign, whereas loosely cohesive or discohesive groups are more often seen in malignant aspirates. And if they are orderly, it's more speaks to a benign lesion versus disorderly cells. Then again, look at the nuclear details. Like we talked about, the malignant ones tend to be coarser, they look more angry, they're more pleomorphic, whereas benign tend to be more smooth nuclear membranes, and the background tends to be clean, whereas in a malignant one, it tends to be more necrotic. So let's go over some of the examples of what we see in cytology of the breast. So let's say the patient is lactating, and you have an aspirate that looks very cellular on low power, but it is mostly predominated by inflammatory cells, neutrophils, and you have few epithelial or ductal looking cells, but they look very reactive with and they tend to be very uh, eye-catching, but at the same time, in a reactive background, you really want to keep away from calling something malignant. So pay attention to the nuclear details. Even though the nuclei look enlarged, the cytoplasm is still, the NC ratio is not that altered. It's not high. And the nuclear membranes are very smooth. So this entity happens because of the bacterial infection from the erosions in the nipple, and usually the bacteria that are involved are Staph aureus. And of course, you would also want to do special stains if you have cell block material to work on, and if you have granulomas. This is another entity that you can see, which is called a subareolar abscess. It's located in the area of the areolar area, where it is not really related to lactation, and it can mimic malignancy. This is due to the squamous metaplasia of the lactiferous ducts, and that can result in a lot of plugging with the keratin and rupture of the duct with a foreign body reaction. The keratin actually attracts a lot of the neutrophils, so you will see neutrophils inside the squamous cell. So that's actually an interesting observation that is noted in a lot of cytology books. And this is benign, but it can recur and have like sinus tracts, so it has to be diagnosed appropriately. This is something like a fat necrosis, which you come across when the patient has a prior procedure, and it can mimic cancer both clinically and mammographically. Usually the smear is hypocellular. You can have inflammatory cells, but also more importantly, you will see a lot of foamy histiocytes and multinucleated giant cells. So your differential would be for fat necrosis could be any granulomatous process. But also remember, if your patient has a ductal carcinoma, and could this mimic that? So, but you have to pay attention to the background in such situations and not overcall it. This is a very tricky situation where a patient has radiation as patients get more and more conservative surgery with the lumpectomy followed by radiation. You have a lot of these very reactive or very ugly pleomorphic looking cells, but pay attention again to the nucleus to cytoplasmic ratio. While the nucleus is really large and there's nucleomegaly, there's also enlargement of the cytoplasm, so that actually there's no increase in nucleus cytoplasmic ratio. Rather, the nucleus to cytoplasmic ratio is low. There is also inflammation in the background, and there will be characteristic multivacuolation of these cells. There'll be multinucleation, and lots in vacuoles are another feature, but you will also see this kind of very reactive process. So this can be a very important diagnostic pitfall, especially when the patient has a history of breast cancer. And when you start looking at these cells, you might call these really atypical cells as positive for malignancy. So be aware of, and if obtaining history of radiation would be very key in this type of situation. This is another entity which is seen during pregnancy, and it's called the lactational changes. And during pregnancy, if the patient is presenting with a discrete mass, the clinician might be a little worried, because pregnancy-associated breast cancers is a very serious condition. So getting an FNA of this mass would be critical. And the smears usually have a very dirty background and a lot of secretion and debris. But notice that although the cellularity is high, but you will see that the nucleus is very uniform across the clusters. So every nucleus looks like the other nucleus. There's no pleomorphism, and they may have prominent nucleoli. So this entity can be a diagnostic pitfall for the inexperienced. So you have to be careful not to overcall it. The secretions here would be the clue that this is related to a pregnancy or lactational changes. Of course, your differential diagnosis would be lymphoma if you have just bare nuclei in the field. So this is how ugly it can look. This is again now high power of the pregnancy or lactational-like changes. Look at the vacuolated and the very the cytoplasm looks very secretory or vacuolated, and you have very prominent nucleoli, but the nuclear membranes are very smooth and regular. There's no pleomorphism among the cells. So on excision, this turned out to be a lactating adenoma. As you can nicely see, a lot of secretions, but you have, it's easier to diagnose on a surgical specimen, but on cytology can be problematic. So here we some of the most common indication I find these days is getting cyst aspirated, and this is mostly very benign appearing, and the majority of the cyst fluids are benign, and a few, like less than 2%, can be malignant. But we still get these specimens. If they are clear or fluid and with foamy macrophages, it's pretty easy to call it benign. I would not call this non-diagnostic, even though you don't have the epithelial cells. Like we talked about the adequacy criteria for breast, you might want to make some exceptions in cases where it's like a cyst content because of the clear fluid that you're getting. So the context is very important. So let's go to another entity that is called the fibrocystic changes. And in surgical pathology, we describe that to be something that has ductal epithelial clusters. You have apocrine metaplastic cells. You have foamy histiocytes. So these are important to recognize because they can be non-proliferative or proliferative. The proliferative ones have a more florid ductal hyperplasia, and the risk for subsequent risk is a little bit higher. So it's important to recognize this entity. And for the non-proliferative, you will see just the regular benign entities with very cohesive cells, and cellularity won't be that impressive. Let's look at this one. Here you see how nicely these cells are forming a monolayered sheet. They are respecting the boundaries. There's no nuclear overlapping. And when you are looking under the microscope, you can lower the condenser and raise the condenser, and you will see little sesame dots, and those are the myoepithelial cells. This cohesive cluster of epithelial cells along with associated myoepithelial cells is a very important clue that this is a benign process, and you should not overcall it as atypical, even though the clusters are large. You will also see associated apocrine metaplastic cells, like in Pap stain, they are more blue-green, but in a Dipwick stain slide, you will find more of the magenta or purple color. So when you start to see a lot more overlapping of the nuclei, and you see a little bit of cribriform spaces, and the cells are falling apart or at the periphery, then your concern for atypia should be there. So you could call this atypical. And again, I'll say this is not an easy diagnosis. There's a lot of overlap between fibrocystic changes, papillomas, fibroadenomas even, because when I describe the fibroadenomas, you will see the antler-like configuration, which you can also see in fibrocystic changes. So a lot of things have to be put in context. So let's go to a more benign entity like a fibroadenoma. This is a biphasic tumor. The FNA can be hypercellular, and they usually form honeycomb sheets, three-dimensional clusters with antler-like fronds. The clue to fibroadenomas is the presence of the background, which has a lot of naked or stripped nuclei, and the presence of stromal fragments. There may be a little cytologic atypia. You can even find intact, isolated single cells in the background, which usually is described more often with malignancy. But in up to 20% of fibroadenomas, you can see it. When your main differential diagnosis would be, of course, a phylloides tumor. And of course, there's a lot of atypia. You might be concerned for carcinoma. Here's an example of a fibroadenoma where you have these branching clusters, and notice the background, it's splattered with all these naked bipolar cells. And this is a very important clue for the biphasic nature of this tumor. And notice these antler-like things. And here is a little stromal fragment. So you have in this one slide, you can put the picture together and say that this is most likely going to be a fibroadenoma. And this is what they talk about, the cohesive clusters with these branching antler-like fronds. And this is the histologic correlate where you have a nice biphasic tumor with both the epithelium and the stromal component, and they don't look alarming. This is just a typical fibroadenoma. Coming to the phylloides tumor, this is very rare and usually occurs at a much older age group compared to the fibroadenoma. You have the similar biphasic pattern, so you will have epithelial and stromal cells. But notice that the stromal cellularity can be, depending on which spectrum it is, from benign to borderline to malignant. It can be very malignant appearing or pleomorphic, where your differential diagnosis becomes a metaplastic carcinoma versus just fibroadenoma. So this challenge remains in cytology as it does in search-path. But one clue for a phylloides tumor is while you see a lot of this background splattering of these bipolar cells, you also see the stromal fragments, and the cellularity of the stroma is very impressive versus a fibroadenoma will not have cellular stroma as cellular as you have in a phylloides tumor. And this is the histology, and you notice how the stroma looks very cellular. There is mitosis here. You can appreciate there's also some epithelial proliferation. And there was a liposarcoma component to this tumor. So this was a malignant phylloides. So this is an entity in a male breast. It's similar in morphology. On cytology, it mimics a fibroepithelial lesion, and you can have these cohesive clusters. You have background bipolar cells. And it is something that, you have a male patient coming in, and with the history is also important, and clinical presentation is important. And in fact, one of the clues they say is when you take the aspirate, it can be painful. Lipoma in a breast is difficult to diagnose. Again, you need imaging and other clinical features because breast is a fatty tissue, so it's really not a classic diagnosis. Papillary neoplasms are very important to diagnose, so the patient can have appropriate follow-up and management. They usually present with nipple discharge, which can be bloody if it is more often bloody with the malignant papillary lesions. And papillary carcinomas by themselves are very rare. The smears are very cellular, and they can be three-dimensional. You will see the whole spectrum, foam cells and apiform cells, which just favors a regular papilloma. But on cytology, very hard to distinguish a papilloma from a papillary carcinoma. So we would just give a diagnosis of a papillary lesion. And when the clinician sees a diagnosis of papillary lesion, they know that they have to go for a surgical biopsy or excision. Here's an example of a papillary neoplasm. Here you can go one step further and favor benign if it has all of those elements. So you have apocrine metaplastic cells, you have some columnar-looking cells in the background, and cohesive ductal cells and some myoepithelial cells. So this turned out to be just an introductive papilloma. And this is an example of a malignant papillary lesion. Here you see the long spindle cells, and these are all columnar type cells. There is hyperchromasia, and the NC ratio is a little high, and this turned out to be a papillary carcinoma. But again, very difficult. If you cannot make favor one over the other, you would still keep it just as a papillary lesion, and the clinician will know how to handle it. So we'll go over some examples. What makes something look malignant is some helpful clues are the cellularity, the arrangement of the cells, the background material, and on higher magnification, you would see also the cellular arrangements, which are very discohesive. You see single, isolated, intact tumor cells. That's a very important clue for malignant aspirates. They are no longer in cohesive clusters. And of course, you look at stromal components. So of course, there is no such thing that if you have tumor cells within a stroma, it indicates invasive. There's a lot of studies trying to show that, these clues can help distinguish invasive from in situ. But on cytology, take my word for it, there is no such distinction. You can find benign glands in fat, but you're not going to call that malignant, correct? So you have to be very careful. You can only call something as a ductal adenocarcinoma if you think it's malignant, without calling it invasive or specifying in situ or invasive. Higher magnification, you see how the chromatin looks very coarse. This clumping of the chromatin. And another feature that is very typical is the comet-shaped nuclei, not only eccentric, but the nuclei seems to be protruding out of the cytoplasm here. Those are the comet cells, and this is considered a very important clue for malignant aspirates. Another example where the NC ratio is altered. So this is an example of a ductal. So as I said, the category would be ductal adenocarcinoma. And these are some of the features we described. Try to obtain a cell block so you can do your prognostic markers like estrogen receptors, PR, and HER2. So again, more examples of plasmacytoid appearance. And this is a histology correlate where you have invasive ductal carcinoma cells invading the stroma. Stroma is reactive and very desmoplastic. So let's go to another less common entity, which is one of the special types of breast cancer, which is lobular cancer. It constitutes up to 5 to 15% of breast cancers. And the biopsies of lobular cancer can be very, very challenging because the cellularity tends to be low. If you remember, lobular cancers, they infiltrate in single file, and the stroma is also very fibrous and desmoplastic. And to find those little small tumor cells in that aspirate could be a limitation. And this is one of the important sources of false negative diagnosis. The more important diagnostic clues would be looking at the nuclear membrane irregularity and also presence of intracytoplasmic lumens. Although this feature is not specific only to to lobular cancers, this can also be found in ductal carcinomas. But just recognizing that this is a suspicious belongs to the suspicious category is probably more important. Here you see the small tumor cells as opposed to the ductal carcinoma cells. Here, the cells are a little bit smaller. And again, pay attention to the nuclear details. In the pap stain slide, you will see coarsening of the chromatin and hyperchromasia. Here's what I'm talking about is the intracytoplasmic lumen. And here you find a little droplet of secretion. And if you were to do a mucin stain in a cell block, this would light up with musicarmin. And you notice in the pap stain slide, the chromatin is really ugly, and there is enough pleomorphism between the cells to call it malignant. And this is a histology correlate. You still see a lot of these tumor cells in the stroma. Let's go to another special type of breast cancer, which is the tubular cancer. Again, very difficult on cytology to make the diagnosis. But this is a very good prognosis cancer, but it is important on cytology specimens not to miss it because, again, it's going to be a hypocellular specimen. But the clue is these rigid outlines and this kind of angular clusters that you see. This is a very common source for false negative. Again, there are other mimics with other benign entities like fibroadenomas, so it is not an easy diagnosis to make. And this is the histology becomes much more easy because here you see these angular glands and they almost have like teardrop shapes and they are in a desmoplastic stroma. So this is a much easier diagnosis to make on histology. This is another special type, mammary carcinoma with medullary features, supposed to have a better prognosis, but the recent WHO classification has put them along with the IDC and ST and not give it a special category. And these usually occur in BRCA patients. They can be, because they're very circumscribed clinically and on imaging, they can be mistaken for a fibroadenoma. And of course, on the cytology specimen, it is very hypercellular. Calling it malignant would not be difficult because they are very pleomorphic. They form syncytial sheets. They also have prominent macronucleoli. This is an example of a mammary carcinoma with medullary features. And here you see this is all the carcinoma looking pretty well circumscribed, but there's a lot of lymphoplasmacytic infiltrate. And in the past, I think this TILS was responsible for the good prognosis that these patients had. Another special type of breast cancer is colloid carcinoma or mucinous carcinoma. It's usually seen in older patients, and you will see again the cellularity can be very minimal, but the background material is very important here because your DIPQuake will highlight this, and even the PAP stain will highlight the mucinous background and these little clusters of tumor cells. Your differential diagnosis would be a mucocele-like lesion and a fibroadenoma with a myxoid degeneration. Moving to another special type is the apocrine carcinomas. These are again rare tumors, less than 1%. They tend to be very hypercellular smears. They can be solid and cystic, so you will see a lot of cystic background. Your differential would be apocrine metaplasia or apocrine adenosis, but really when you see this entity, they are very, very ugly with big prominent nucleoli. And this is the histology correlate where you see the stromal architecture is very more telling for an invasive process where the tumor nests are infiltrating the desmoplastic stroma. Occasionally you come across primary or part of a systemic process, lymphoma within the breast, and they usually tend to be the B-cell type of lymphoma, diffuse large cell. They tend to be more like single cells, and here your differential diagnosis would be a very poorly differentiated ductal cancer. But look for lymphoglandular bodies, which are little cytoplasmic fragments that will be seen in the background. Also pretty rare. Rarely you will see a primary squamous cell carcinoma of the breast, and you can recognize squamous differentiation because the Pap-Nicolau stain is really helpful in highlighting these dense cytoplasmic structures. Another cytology specimen that you would come across is when a patient has a pleural effusion and the patient has a history of breast cancer, you are mandated to examine and rule out a metastatic process, and a cell block will be very helpful. You see a lot of epithelial clusters in this pleural effusion specimen. So your key after important thing to do after you make a diagnosis of metastatic carcinoma is to salvage material and get your biomarkers done, especially ER/PR and HER2 is key in helping the management of this patient. Of course, you will have to also come across an FNA of an axillary lymph node as one of your cytology specimens. And here you will see a lot of epithelial cells. So if you're in a lymph node, you don't expect to see epithelial cells. So this is even without the background of lymph. Sometimes the lymph node can be completely replaced. And so it's important to recognize tumor cells. And the thin prep highlights the clean background, but you also see a lot of the tumor cells. So the other applications of cytology is the touch prep, like we talked about, as lymph node, and at the intraoperative assessment of surgical margins of lumpectomy. I think this is so rare, we don't even do a frozen section these days. So this, I think, is probably not feasible at this time. Touch prep of lymph node mets is sometimes very helpful when the lymph node comes for frozen section, and while the section is being cut, you could do a quick touch prep to get a clue whether this is going to be malignant or not. And you see a lot of lymphocytes in the background, but here you see a cluster of tumor cells. So this is helpful. So rarely you have tumors that metastasize to the breast. So you have to think about not just the primary when you're aspirating the breast. There's when the patient has a history of melanoma, or so getting a history is very important. And so 5% of malignant breast tumors are metastatic to the breast. So history of lung or melanoma or lymphoma is going to be helpful. So if you want, you can guess what this is. So this looks very plasmacytoid, right? So this patient had a history of melanoma, and we did some stains and proved it was melanoma. Patient had a history of lung cancer, but what is striking here is the presence of this molding and very high NC ratio cells. So this was a small cell carcinoma of the lung that had metastasized to the breast. So if you want to do the breakout sessions, I have 4 cases. If there's no time, we can just go over these cases. And if the audience wants to answer, that's fine. Otherwise, we can. So how do you want me to proceed?
Uh,
So,
I would say because we're fairly low in numbers, I think we can just stick together. We have,
okay.
I think, enough for everybody to participate reasonably in that context.
Okay, I can just quiz and I can wait for their answer. Anybody in the audience can answer, and then I can show you what I think it is. So this is a case 1 where the patient is a 40-year-old woman and she presents with a painless breast mass. This is the diff quick stain slide, and you see there are cells that are kind of small and large. Some of them have prominent nucleoli. This is the diff-quick, you remember, exaggerates the difference between cytoplasm and nucleus. So just looking at the diff-quick, don't jump to conclusions. So there is also look at the pap stain slide. And here you can see the cytoplasm is extreme. The background is what catches your eye. And you see the nuclei not looking very ugly, but the background has a lot of grungy material. So pay attention to this material and let me know your thoughts. Do you think this is something that you would consider put it in the benign category or malignant category?
I'm going to pick on somebody. So, Anjali, why don't you go first?
I think it's malignant because of high NC ratio.
Yeah, you think about, I mean, it does have variable size, but I showed you the malignant aspirate, those were pretty large and they were intact single cells in the background. Here it's all a very granular, grungy background. So do you want to rethink your diagnosis? Maybe. Okay, this was very difficult. Actually, it was somebody had to, even Dr. Deme was scratching his head when he had this aspirate. So I take pride in the fact that I diagnosed it. So I will tell you what it is. So this was actually a granular cell tumor. And you see these little histiocytoid looking cells. And this is the benign breast duct in context. And this can, on histology too, can be worrisome because it has an infiltrative growth pattern. But overall, it's very, very bland looking cell. So you actually think it could be histiocytic. So a granular cell tumor can mimic breast cancer both clinically and microscopically, and usually it's the origin is from the Schwann cell. And we have special stains to do to determine whether this is epithelial or of nerve origin. So usually they are S100 positive and they are negative for keratitis. They can be CD68 positive. So this is a second case. The patient is a 45-year-old woman, and she presents with a breast mass. And this again was a challenging case. So if you get it wrong, you're fine. But if you want to try, you can. They are cohesive clusters of cells. Some of them are forming acini here, like little cribriform spaces. This is the dipwick where you see more of a purplish hue to it, whereas the pap stain is more blue and gray or green in color. So with this, what would your diagnosis be towards? Like, is this benign malignant, or do you think of any particular specific entity?
That looks more like benign to me because they're like well arranged. They are like together. I cannot see exactly the nuclei, but that's my gut feeling.
Yeah, you are right. It is one of the entities that's extremely rare, even in the breast. This is the adenoid cystic carcinoma, and you see these little cribriform glands here. And this was the core needle biopsy of the specimen that actually showed these little hyperchromatic nuclei that formed little cribriform spaces like glands. And this is epithelial, and it has both the epithelial and myoepithelial cells. So you would have to work it up, of course. The excisional biopsy showed again this collagenous material. So if you go back to that slide, this basement material is what you're seeing here. So that actually catches your eye here. This is the kind of material that, and the nuclei are circling around it. So you have the myoepithelial cells around the collagen balls. So once you see this picture in cytology, you will not forget it. And of course, on the excision, you have a lot of stains that will help you determine the diagnosis. So just having this cribriforming is, you would be even considering invasive cribriform carcinoma. But the basement membrane material is your clue to the diagnosis. So collagen 4 would be positive in that. And P63, a myoepithelial stain, will pick up the myoepithelial cells.
Is
So
there
let's
any
go to
crossover with collagenous spherulosis on the cytology?
Absolutely, yeah, that is in the differential diagnosis, but collagenous spherulosis will not form a mass, whereas adenoid cystic, it's more like an incidental finding where you see it with a sclerosing lesion. And they can stain the same way. So basically, collagenous spherulosis, only it's a more clinical diagnosis.
Yeah.
Like it's mass forming versus is not mass forming, whereas adenoid cystic forms a mass. The staining pattern can be the same. They can also be sick yet positive, like adenoid cystic carcinomas.
Wow.
Yeah. So this is case number 3. Here is a 45-year-old woman who presented with an irregular lump in her left breast. And of course, any volunteers who can take it. It looks alarming, but if you call it malignant, you're forgiven. So I've given you a clue. So it's benign. So go ahead. And what do you think? Why do you think it's benign?
Looks like giant cell.
Exactly. That's the perfect answer. Perfect answer. That's multinucleated giant cell here. And these are all these vacuolated cells. So if I told you the patient had an implant, a silicone implant, and you had a microscope and there's refractile material within this giant cells, what would you be thinking? Right? It's related to the silicone actually is leaked out of those implants, and this is like the reactive process to a silicone. And in the past, they thought it was associated with connective tissue disease and with the implants, but I think at this time there's little literature to support that. They usually tend to have these vacuolated macrophages containing refractile material. Let's go to the last case. Here we have a 42-year-old female, again, breast implant. She had, here we got a history, patient has a breast implant, and there was fluid so in the immediate space around the implant, and this was aspirated. A cell block was made, and this is the material you're seeing in the cell block. And you can tell me what you think this is. Normally, when you get an implant fluid, would you see this much of cellularity?
No.
Correct. So it looks abnormal right off the bat, and you see a lot of abnormal cells, some with horseshoe-shaped nuclei, very pleomorphic multinucleated cells. So clearly, whenever we get implant fluid for cytology, they always ask us to do a CD30, and the reason being they want to exclude an implant-associated anaplastic lymphoma that is of T-cell origin. And so the CD30 will be strongly positive, CD4 will be positive, and the relevant negative states are the A1, A3. So In this particular case, it was very helpful because they even sent the same material for flow, but the flow did not capture these cells. It was in the cell block material that we actually got the diagnosis, and this was published in Diagnostic Cytopathology maybe a few years ago. In plant associated it's very rare actually, and so it's important to when you see something like this to actually publish it because there are very few reports. So in conclusion, I like to say that there are some advantages for FNA because of the quick diagnosis. It's an on-site assessment, and so therefore you can assess for adequacy. You can avoid unnecessary surgery, especially in pregnant and lactating women if you diagnose it as a lactating adenoma. And currently, the most important use for FNA, I would say, is doing an FNA of an enlarged lymph node to see if she's lymph node positive just prior to neoadjuvant treatment. And they usually leave a clip inside that node. Even with the core biopsy is also replaced that now. Some institutions still do FNA, but some continue to do the core biopsy. Of course, the most important disadvantage is, of course, distinguishing between in situ and invasive, and the presence or absence of LVI cannot be said. Ancillary studies cannot be performed in a limited material, but I've seen some cytopathologists have been very aggressively taking material, and I think we have enough material to do ancillary studies too. And there's good concordance between for biomarkers, especially for ER, between the core biopsy and the cytology specimen, and not so much for PR, but fairly high concordance. And then for HER2, again, it's not that great, but there are limitations, I'd say. So therefore, needle core biopsy has now overtaken FNA. Many institutions, there's only reason to do an FNA of the breast is to get cyst fluids or the core or the FNA of the lymph node. The advantage is the larger sample size you have, and most pathologists are comfortable with architectural and stromal relationship, which can be obtained in a good cell block preparation, and the predictive and prognostic markers are superior. If you get a core biopsy, you have a lot of material. Of course, the disadvantage would be the expense, processing time, and complications, again, bleeding and needle tract seeding by malignant cells. So I would say this is the decline, unfortunately. It was popular for some time, but not so popular now. I guess that's the end.
Hey, that's just great, Malini. One of the things that stands out to me here as you've been talking and showing these cases is what a help it is to study cytology, and that makes you a better histopathologist. You learn those subtle clues that otherwise just go over your head under the microscope with a tissue sample. And so I've long been an advocate that, when you have a surgical specimen of even many routine things, that it's often useful to do touch preps or to do a needle aspirate of the surgical specimen so that you can learn, what those cytologic features might be that you might encounter in the event you had an FNA, or in the event that you had it, and you'll see other things as well. So I think it's a great way to study and learn some of the details of histopathology that otherwise sort of get lost in the instructional milieu.
Yeah, I agree. It has just always fascinated me, cytology. And, even when you get a specimen for frozen section, it is always nice to do a touch prep of the specimen, or in the grossing room, just do a scrape preparation. The cytology gives you a lot more information, and, you see the cells, a very viable looking cell. So it's fascinating. Yeah. I think it also helps you think and put the puzzle in your mind. But not all people like cytology, I must say. There are few people who cannot do cytology, and for them, search path is the way to go. But I think in some countries, I think cytology may still have a lot of utility.
So I think Ashley wrote a question in the chat earlier on in your comments. Do you want to clarify your question about architecture and cellular changes versus suspicious?
Oh yeah. It's just because I'm a PGY1, so I'm still a baby. Um, I still have a hard time like to say if a specimen's like more benign or malignant, because sometimes I see the architecture looks a lot like malignant, but um many of my attendees say like, hey, but you need to look into the cellular aspect. So I was wondering if you need to always combine the architecture and also the cellular characters to call it like cancer or like a typical or suspicious. How does it work in cytopathology?
Yeah, so you don't always have the luxury of looking at architecture unless you have a good cell block preparation. But if you have only the smear, you have to, again, there's always the cellularity is helpful, but like I told you, there are exceptions. Some fibroadenomas can be very cellular, fibrocystic changes can be cellular. So that doesn't really put it in the benign or malignant cap. So you would have to take into account the constellation of features that will help you. So you would have to look at the cytology of the specimen, the background material that is available. Is that so? It's not it's just like putting pieces of puzzle together. It comes with practice. So I won't say that it's the easiest way to do it, but having using criteria that will help you. Looking at low power systematically, going to high power, looking at cellular details. All of that is key.
Okay, thank you.
Thank
You know, and
you.
I'll just make an added comment about the terminology suspicious
Yeah.
and positive or whatever. In cytology, we tend to be fairly explicit about kind of what the criteria are that makes it suspicious versus malignant or
Mhm.
suspicious versus just atypical or uncertain. And we're moving towards categorizations
Mhm.
kind of on a 5-point scale usually between
Mhm.
benign and malignant. But in surgical pathology, we don't quite have that those criteria spelled out as clearly. And so one person uses suspicious, and they're like 85% convinced that it's cancer, and another person may use the term suspicious when they're 50% concerned or something like that. And so you have to make sure that you understand what scale they're using and what the criteria are on which you're going to make that distinction between what term you use in that regard.
Oh,
True.
okay, different threshold. Okay.
So, any other questions for Malini? We've gone a little bit over the hour, but it's been very productive.
Okay. I look forward to seeing all of you again.
All right. Well, we will
Thank you
definitely
so
try to
much.
do this again. And thanks everyone for joining and for good preparation. And we will see you next time.
Thank you. Bye-bye.
Thank you.
Thank you. Thank you.